I will now introduce the speakers and the moderator for today. First of all, we're starting off with Mike O'Brien, who is the Technical Director of FHI 360's Crisis Response and Resilience Department, overseeing the humanitarian sectors of health, WASH, protection, nutrition, and monitoring and evaluation. He specializes in humanitarian emergencies related to natural disasters, conflict, mass displacement, and disease outbreaks, with 5 years of U.S. domestic public health experience and over 17 years of international work. Next, Alessandro Iamo is the Senior Nutrition Advisor for FHI 360's Crisis Response and Resilience Department, specialized in public health and emergency nutrition programming, with more than 20 years of experience in development and humanitarian contexts, with the focus on management of wasting in maternal, infant, and young child nutrition. Dr. Celestine Amika Ikwaluo is a dedicated physician nutrition coordinator for FHI 360's Crisis Response and Resilience team in Ukraine. With over 12 years of international public health experience, he has deep expertise in health system strengthening, disaster risk reduction, nutrition-focused cluster coordination, and integrated multi-sectoral programming. Dr. Cisse Demek is the Health and Nutrition Coordinator for FHI 360's Crisis Response and Resilience Project in Ethiopia. He brings over 10 years of experience in clinical and humanitarian health and nutrition programs, having worked with various governmental organizations as well as international non-governmental organizations in Ethiopia. Solomon Atuman is the Nutrition Coordinator for FHI 360 Crisis Response and Resilience in Northeast Nigeria, where he leads emergency nutrition interventions across conflict-affected regions. With over 10 years of experience in humanitarian nutrition programming, Solomon specializes in responses to conflict, displacement, disease outbreaks, and natural disasters. And now I'd like to introduce our moderator. Doreen Alumaya is currently a doctoral student at UNC Chapel Hill and has prior experience working as a nutritionist in a refugee camp in Uganda and as a research scholar at Otterbein University. And without further ado, I will turn it over to our speakers. And once again, please use the Q&A box to submit questions you may have as we move through these presentations. And thank you all once again for joining us today.
Thanks, Nia. I think we can go to the next slide. Yeah, and thanks, Fine COP, for having us back. And thank you all for joining. I've got a rhetorical question you don't have to answer, maybe answer internally for our participants. And it's basically, have you eaten today? You know, it's 9 a.m. here on the East Coast of the US, and I haven't had anything to eat yet, and I'm noticing it. And I also notice it's something that I have to think about constantly. It's something that I have to think about now. Have I eaten enough today? Will I eat enough tomorrow? Have I eaten too much, which is usually my problem? What am I going to eat? Is it the right mixture? Is it the right nutrients? And the biggest problem is I've got a 7-year-old, and I've also got to think about the 7-year-old. And my particular problem isn't much of a problem. You know, it's mostly about planning. But you can think about, you know, we have to think about what we're going to eat all the time. And just imagine the people in crises and them thinking, okay, am I going to have a meal tomorrow? Is my kid going to have a meal tomorrow? I'm a breastfeeding mother. Am I going to be able to produce milk? You know, am I going to have problems with that? If my baby can't breastfeed, then what am I going to do to make sure they do get the right nutrients? You know, so these are the perpetual problems that we have, that I'm so thankful that I work with a great group of specialists, nutrition specialists, that can help people that are in crises answer these questions. And they don't answer it for them, they answer it with them. So that's what you're really going to hear today, about the work that FHI 360 and our humanitarian programs do in Ukraine, in Nigeria, in Ethiopia, to help people to address these day-to-day problems that they have, on top of conflict, on top of disease outbreaks, on top of other health issues and things that they have to deal with. So that's basically what they're going to be talking about today. You can see it here in the outline. We're going to talk about a little bit about mother-to-mother peer groups. You know, IDPs are internally displaced persons. You can think about them as refugees, but with a special, unique set of challenges because they're still within their host country, but they don't really have a place to permanently live. Infant, young child feeding and emergencies in conflict in Ukraine, which is not something you would typically think about, but which is a real issue that we're helping people to address. Next slide, please. But the real thing is, it's not just about nutrition. It's sort of all the issues that kind of come along with it, because each one of little issues, whether it's nutrition, whether it's I don't have clean water, or I don't have access to safe sanitation, if it's somebody in my household is sick and I'm starting to feel a little bit sick, each one of these is just a drop in the overall pond of health, and they have ripple effects, and each one affects the other. So it's extremely important to really consider nutrition not just as nutrition, and not just as nutrition and food security, but nutrition holistically, and making sure that we understand sort of all of the challenges that are around families in trying to meet their nutritional needs. Because we do know that if they have a dirty floor, then they're more likely to have soil transmitted, worms, and basically that could impact their nutrition, which will then impact their development and their learning and their education and future livelihoods. So it's all kind of interconnected, and that's how we try to address it at FHI 360. So please think about your questions, think about your experiences, think about what you'd like to get out of this session. And I just encourage you to engage with the panelists. So over to you, Alessandro.
Thanks, Michael, for the very kind and informative introduction. So let me start saying that all the work and the experience that we are going to share with you colleagues, and hopefully we can disseminate it even further when we will share the recordings and the related materials, is inspired by a collective effort. And that's the collective effort of the Infant Feeding in Emergency Core Group, of which FHI 360 is a member. We are also part of the steering committee. And there are so many resources that I think you would all benefit in case you are not familiar or you have not yet accessed them. But just to say that the work of FHI 360 is also work that is made in a collective and in a way that we share and collaborate with other partners to identify the best strategies and approaches that we can deploy in our work. Next. Just two key messages from this slide and the following one. One is to reiterate, and maybe there is no need for this audience, but to reiterate how infant-young-child feeding is a life-saving intervention. The breastfeeding case, the complementary feeding case, but basically is to be reminded and to remind our own organizations, we are all complex and sometimes matrix organization, that we should prioritize the protection, promotion, and support of infant and young child feeding in emergency, because it does help prevent deaths and improve the quality of life of the population affected by emergency, mainly the most vulnerable, women and their infants. Next. But at the same time, we need to be reminded of the continuous challenges, among others, and this is all based on the evidence that we have been generating with partners and colleagues across the various networks. And some of them I'm going to read is basically the general lack of support and attention to infant and young child feeding within our emergency responses, not investing, not considering even the importance of key activities within our emergency response plans. And we are going to highlight some aspects on what we were able to do, sometimes the limited or no engagement of the communities or the families themselves in ensuring that they can protect and support infantile and child feeding. One of the perennial, historical, and current challenge is really the widespread donations of formula and commercially produced complementary foods during emergencies, and how companies, and again, this has been all is supported by the evidence that we have compiled over the years, how companies sometimes do exploit emergency to push products in the context affected by these emergencies. So this is just to frame in what context we have to provide support, and we try to provide support in our humanitarian context. Next. I will briefly present an effort, and it's very important, unfortunately on behalf of our Yemen team that is currently not operational due to the US government stop work orders. But we felt was important a way of demonstrating or illustrating a way of engaging families and engaging communities. Next. And it's really engaging through co-designing or understanding together what are the priorities and the issues that we need to work with them as part of the emergency response. So what we did as FHI 360 in Yemen was really to engage communities, including pregnant women, the mothers, the fathers, and the volunteers and the various health workers that were all trying to respond to the ongoing chronic emergency in the West Coast. Next. And we tried to ask the community, we tried to ask these women and these men what was working for them, what was working in terms of helping increase access to nutrition services in particular. And they all highlighted, and that was very important, the role of their peers, their community volunteers, in ensuring that they are informed, that their children are regularly screened, and they ensure that they receive the most up-to-date information. So that was a very important validation from the community and the families themselves. Next. The second was to identify with them, to ask the families to help us understand what was hindering access to nutrition services. And they help us identify several, and the one on this slide are just an example: the distance to the facilities, the inability to take care of the children that were not, they were not the one that needed to be brought to the facilities, connected to the distance, the issue of transportation, the heat in that context, and the fact that facility was maybe also creating some barriers, putting schedules, and if we miss the schedule, how do we catch up, and so on. Next. So that co-assessment, working together to identify both the strengths and the gaps that we were meant to respond to, help us provide some clear insights, and basically insight on how to expand our community-based delivery system, how to strengthen our CHV training, how to invest in transport-sensitive referrals, and of course, work between health workers and families to improve the quality of the health services. This helped redesign the project and ensure investments were going towards these areas. But again, as I said, unfortunately, due to the stop work order, we were not able to roll it out. But it's an important effort, and we should not forget that the collaboration and engagement starts at the onset, starts at the needs analysis, and we need to do it with the families. Thank you. Over to you, Sisai.
Thank you, Alex. Good morning, good afternoon, everyone. Before I proceed with my presentation, I would like to extend my appreciation for the organizer, for the panelists, most importantly for the participant, for the resilience, for the endurance and solidarity that showed after what happened last week. Today, I'll share you our experience in supporting mother-to-mother support groups in host community and in IDPs in Ethiopia, and how this peer-based support brings meaningful change in nutrition. Next slide, please. Okay, let me start my presentation with the overall humanitarian and nutrition context of Ethiopia. Ethiopia continues to face significant humanitarian assistance need. Back in 2021, over 34 million people needed humanitarian assistance. And recently that number reduced, but still it's in alarming state, which is around 60.3 million people needs humanitarian assistance. When we see specifically the nutrition, the recent Smart Plus survey in Tigray shows that 23% of GAM rate for children and 68% of GAM for PLW. And nationally, wasting cities around 11.3%, which is above the emergency threshold. There is compounding driving factors for this crisis, and the main one is the conflict. The conflict in the northern Ethiopia, mainly in Tigray and Amhara, drives a community to be displaced from their house, and it affects their health and nutrition service utilization. The other one is the drought in Somalia and in other part of the country, with the level of IPC for phase classification, which is one step below the famine. And the other one is health system disruption and repeated and protracted outbreaks, which affected already disrupted health system. Next slide, please. Okay, to give you some overview about FHI 360's integrated response. Our response combines life-saving intervention in nutrition, health, wash, and protection. As the problem in the community is integrated, it's also our intervention. In nutrition, we have different activities, and one of that is community-based management of acute malnutrition to early detect and manage moderate and severe acute malnutrition. The other one is infant, young child feeding in emergency. And as I said earlier, supporting mother-to-mother support groups and other community-based platforms is other core component in our nutrition sector. And the other one is recently we piloted Cash for Nutrition Assistance, which is aimed to support recovery and relapse for children recently discharged from some treatment program. In health sector, we focus on essential health services and provision of health services for underserved populations, even in hard to reach areas and in IDPs through mobile medical unit and health system support. And the other one is providing pharmaceuticals and medical commodities to ensure that the continuity of cares in the health facility. In our wash sector, we focus mainly wash in health facilities, water supply maintenance, hygiene and sanitation, and environmental health. In protection, we focus on GBB prevention through community awareness and referring or providing service for GBB survivors, including clinical, psychosocial support, and referrals. So by integrating these sectors, we aim to provide comprehensive and context-responsive support to provide support for immediate and long-term problems. Next slide, please. Okay, as a community-based nutrition component, we adopt and practice mother-to-mother support group discussion, because this model enhances the role of family inclusion and community engagement in nutrition practice, because this model is peer-based education and support, which enables for experience sharing among mothers that increases their nutritional knowledge and build confidence among mothers. This model also helps to engage the community, and it also helps to increase ownership, and it's culturally relevant for mothers, And beyond the nutrition, it also helps to the mother for increase their leadership and emotional support, which is very important in humanitarian setting. To practice and adopt this model, we worked with all stakeholders at all levels, mainly with health extension workers and IDP committee members. We participate all stakeholders in selection of lead mothers. Those selected lead mothers received 3 days of training on optimal child and maternal nutrition. After they received their training, those mothers registered other mothers to establish the group with the help of health extension workers and other community leaders and IDP committee members.
Sorry to interrupt, Cisse. We're going to have to, if you could wrap up very quickly, we'll move on to the next presentation.
Okay, next slide, please. Next slide, please. Okay, by doing this practice, we have achieved a lot of promising results, like 250 mother-to-mother support groups is established, like 500 lead mothers is trained, and around 6,000 cooking demonstration is organized to show practically the cooking demonstration for complementary feeding based on the locally available foods. And more importantly, more than 80,000 children is screened for malnutrition by mothers, which ensure early detection and treatment. And because of the mother-to-mother support group defaulted, some cases is returned back to program, and house-to-house visits also increased, and self-referrals from the community is increased because of this mother-to-mother support group discussion. Next slide, please. So for the next, we have a plan to scale up and expanding this practice in our intervention area and others. And the other one is we have a plan to improve quality and standardization of our mother-to-mother support group discussion and the activity. And we also plan to use this platform as a leveraging and as a contact point for other community-based health and nutrition services, like regular growth monitoring and promotion activity, immunization, ANC, pregnancy conference, and the others. And the other one is we have also a plan to conduct a robust evaluation and to learn from our practice. Thank you very much. Now I would like to hand over the floor to my dear friend and colleague to Solomon Othman.
Yeah, thank you so much, Cisse. Good morning, good afternoon, everybody. So today I'll be sharing our experience in engaging families through peer support initiatives in Nigeria, Northeast Nigeria, particularly in Borno State, where we've been responding to the nutritional challenges in this humanitarian context. Next slide, please. Yeah, so as you may know, Borno State has been at the center of a complex humanitarian emergency since 2009. This has mainly been through, the main driver has been the armed insurgency, also aggravated by disease outbreaks and natural disasters such as floods that we've experienced in this area. We know we currently have more than 2 million internal displaced persons, and according to UN OCHA this year, over 8 million people are in need of humanitarian assistance. If you put this, if you combine this with the disrupted, health service and infrastructure system, that we are faced with a very serious need down here. Just to also highlight that since 2017, FHI 360 has been providing a multi-sectoral intervention to meet the needs of these people in Borno State. Next slide, please. Yeah, I'm sure you asked what are the issues we are trying to highlight or to deal with. Majorly, we see that in emergency settings, child mortality can escalate up to 70 times more than the average for of 2 times in normal settings. We see a very stark and high GAM rates above emergency thresholds. We also have seen through several research and studies that IYCF practices have been very poor. And like I earlier highlighted, the population mostly are internally displaced persons who have limited access and access to the basics of life, as you can put it. So these are some of the issues we are trying to address in this area. Then combined with the context, as you will see in the next slide. So just to give us, some level of context for Borno State, we see that both men and women have shared responsibility as it regards to the care and nurturing of a child, as well as prevention of undernutrition. But what we have here is that mothers are usually the primary caregivers for those children. Yet the fathers control, the dynamics in the house. They control decision-making around food purchases. They control decision-making around healthcare access, and even the decision of where to get the healthcare services, as well as control decisions around caregiving. This dynamic means that both the parents must be engaged effectively across child across the child nurturing to prevent undernutrition, and also ensure that the best outcome possible is reached for that child. We also know that food insecurity has complicated the situation, making it essential, for us to involve all the family members in nutrition intervention. Next slide, please.
You have about 1 minute remaining.
Yes, next slide. Yeah, so our family-centered approach is, get around addressing these challenges, as I earlier highlighted, through, peer support groups. The first is that we have the mother-to-mother support group, where mothers come together and discuss around child upbringing, as well as infant and young child practices, infant and young child feeding practices. The next is the father-to-father support group. Like I earlier explained, the fathers, the context here is a bit different. So we brought the fathers together to also have this forum to be able to share information on IYCF, and then provide mutual support to one another, as well as learn from one another. Just to highlight that these are not lectures, these are forums where participants feel free to reflect and share their beliefs, as well as their doubts, and provide mutual support to each other. Next slide. Yes, so these are the processes through which we took, engage in peer support groups. We start from planning. Planning starts from the stage of the program design up to when each and every one of those participants is graduated from the support group, and now they are unleashed into the society as IYCF champions, to be able to carry on the good work to other members of the society that may not have had access to the peer support group. Next slide, please. Yeah, so we've been able to, in terms of result, we've been able to achieve, establish over 4,000 support groups, and we've reached nearly 500,000 people with through these forums. We've also been able to engage both the fathers, the mothers, the grandparents, and other family members that have been involved in childcare in the society or in the community. We've seen an improvement in exclusive breastfeeding rate from 33% to 64.8%, while there may be other factors involved, but this was what we've been able to get across the locations where we've been implementing. Beyond these numbers, we've also seen, success stories from participants where, for example, Mala Abacha, once skeptical about colostrum, is now an advocate for the use of and the importance of colostrum. Next slide, please. Yes, so in terms of lessons learned for the future, we know that we've seen and we've known that peer support group works. They help in dispelling myths, build trust, and they can reduce isolation for members of the society. And then we know that also inclusive engagement is also very key. Involving fathers, strengthening household decision-making and IYCF uptake. And we have seen champions who influence their communities through these platforms. We also know that gender-sensitive design is essential for equitable impact, as well as skill facilitation is also very, very key. Next slide, please. Thank you so much, and I will be handing over to my colleague Celestine for his presentation. Thank you.
Okay, thank you, everyone. I will be presenting on engaging families to protect and support IYCF in conflict affected for Ukraine. Please, next slide. Just for the context, we all know that the Russia-Ukraine war started in 2022. There's been widespread misinformation, DMS donation. Women and their husbands face uncertainty about feeding. And about to date, 373,000 women of reproductive age need targeted support. For FHI, we are implementing in 5 oblasts, Kharkiv, Dnipro, Zaporizhia, Mykolaiv, and Odessa. Next slide. Some of the things we do to reach families and engage women is by the use of master IYCF counselors who provide case counseling to fathers, to mothers, and their caregivers. We also have IYCF corners. We are safe spaces where people can come together, breastfeed their children, also learn. And we've also ensured that fathers, where possible, are included in our group sessions and the School of Parenting models. Next slide. Some of the things that we've been doing so far is the health facility-based counseling. So as at the end of last month, we've reached about 19,000. And we're also doing IYCF programming through social media. I think this is something that is unique to Ukraine, which I believe that other people can leverage about this opportunity and learn using our chatbot, which we'll present in detail. And we've also been doing training and coaching of health workers. And we've trained about 641 health workers. Some of the lessons learned is on the data that we've reached and our coverage, and trust that grows when both parents accept same accurate information, shared learning with mother and father, which reduces harmful myths, because obviously this we really improve and joint decision making. And we've been linking, there's been a strong linkage of mental health and GBV, to our programming. One husband will say, I now join counseling. My husband, a woman will say that her husband now joins counseling, and he now reminds her of what the counselor shared, which means discussing breastfeeding and IYCF is no longer a challenge within the family. Next slide, please. One key innovation, which I'm not so sure, but I believe this is one key innovation from the Ukraine angle, is in the introduction of AI, artificial intelligence, which all know that is currently popular across the globe. Now, we've moved our IYCF into ensuring that we now use an AI-enabled support. And for us, it's an AI chatbot, which is hosted on Telegram. It's a 24-hour service. It's self-paced, and anybody can actually access it. It has interactive videos and posters. Anybody, including fathers and caregivers, can ask questions and strengthen their role in infant care. And what we did was to leverage the ChatGPT, which we all know, and OpenAI, for intelligent interaction. And we also put some materials on the back end. And through SendPulse for automation, and using the Telegram link. From SendPulse, you can actually use any link you want, but we chose the Telegram because Telegram is the most popular app in Ukraine. Next slide, please. What are the ways to scale family engagement, and what is the way forward for IYCF in Ukraine? One is to expand family inclusive counseling and AI to help them to new oblasts. Currently, we're in 5 oblasts. Oblasts, for context, is something like states in other countries. So we plan to scale up to another states to develop more content that are targeted at fathers and grandparents, because most of the contents now are currently targeted at women and and yeah, women and mothers of childbearing age. And again, to strengthen family-based peer support groups to build solidarity in displacement. What we are trying to do is to ensure that the mothers learn, the fathers learn, and at the end of the day, the community support IYCF practices. Next slide, please. Thank you so much. I'm much appreciated.
Thank you so much to all our speakers for those insightful presentations. It was really inspiring, to hear these country-specific examples from Yemen to Ethiopia to Nigeria and to Ukraine. We'll go a little bit deeper into the conversation with our panel conversations. I'll start with a few questions that we have for our panelists today, and then we'll move into some of the questions that we received, either when you registered or you're sharing through the chat. And please feel free to share any of those questions in the chat. We'll make sure we get to them as much as we can. So yeah, Sise, first of all, thank you so much for sharing those experiences from Ethiopia about mobilizing families in IDP camps. It really highlighted the power in local solutions. To build on that, what role do you think a community of practice like this can, play in getting families even more involved in nutrition efforts in IDP camps?
Okay, thank you very much. That's a good question. Yes, to address this question, I want to just ask the participants to think about the setups of IDPs, which is much different from the refugees. And in most of the IDPs, there is no community structures, and the mothers are not stable enough.
Okay. I think we lost Dr. Sise there for a minute. While he's reconnecting, Solomon, I wanted to just quickly come back to you. Your presentation sort of gave us this great view of father engagement and how this has been approached in the context of Nigeria. Just building on in that, in emergency settings where traditional caregiving roles are disrupted, how can we effectively engage fathers and other non-traditional caregivers in infant and young child feeding without reinforcing harmful gender norms?
Yeah, thank you so much, Doreen, for that question. So first, let me start with saying the disruption presents both a challenge as well as an opportunity to reimagine, caregiving in a way that is inclusive and transformative. So we found that engaging other non-traditional members like the grandmothers and the fathers, or the male community at large requires some level of deliberate and cultural sensitive approaches. So what we try to do is to create a platform where we don't tell them what to do, but they hear from other men, how things are done and how they have been able to engage in caregiving. And this design does not only help, in challenging the norm, but it helps, it does not reinforce, those stereotypes that we are used to seeing. For example, we know, like when we first started, we started with the mother-to-mother support group. We saw that even though the women learned what to do, they've gotten the skill. It was difficult for them to implement at home because the men now are the decision makers. But when you have a combination of both of them having this, the uptake becomes way higher and easier. So basically, it is to say that the goal is not to replace one with another, but it is to, expand the scope of, caregiving, expand the circle of caregiving where both the male and the female have an opportunity to, improve the infant and young child feeding practices in the home front. Thank you.
Thank you so much, Solomon. I really like how you emphasized the shared responsibility in the work and not an act of replacing the other practices that often reinforce the gender norms we see. Thank you so much for sharing that. Celestine, just coming to look at the work in Ukraine that you shared, very innovative, especially given this very complex context, and I did see highlighting the use of AI. How can innovative IYCF and infant feeding in emergencies, specifically strategies like those developed in Ukraine's conflict zones, be adopted globally? What lessons do you think we can learn, and how can we adopt this?
Thank you so much for this question. Something unique and innovative, peculiar to Ukraine, is the use of the innovative AI, which I just talked about. We all understand or know that, I mean, right nowadays we talk about artificial intelligence. It's now part of our life. And we can actually integrate that or mainstream it into the humanitarian settings and even in the development settings. In Ukraine, we've done that with our chatbots, with our sensors, linking them together with the ChatGPT and building our backends to make sure that information is dated. Also with the data protection policy, making sure that the ethical aspect also is well maintained. What are the few things that we observed? We observed that this provides us an opportunity that our programming can actually be scaled. It can be scaled to a great extent more than we had actually imagined. We are now designing programs that are culturally sensitive, especially where you have things like a multilingual nation, multilingual, we know, for instance, and things like India, things like Nigeria, many countries, in fact, even in Ukraine, so some people speak Russian and some others speak Ukraine. I understand that there might be some few dialects there and there, but this innovative AI bridges this gap. Disseminating nutrition information via social media also gives you the ability to have a live chat, more of like with a booth, and that provides you a guidance and also signposts you, to the master lactation counselors and the health workers who can come in if you feel that you need additional support. Again, it's a 24-hour service, which means you can access the service at any point in time, even from your bedroom. And more importantly, is that it's been also supporting the health workers that they can actually leverage this. It's not just about services to beneficiary. It's also now used by the health workers, to things like personalized feeding plans, and also support them in updating, the best practices that exist, not just in Ukraine, but across the globe. This can actually be scaled to other countries, and it will make implementing humanitarian services, especially in IYCF and even in SEMA, more robust, more scalable, more innovative, and at the end of the day, more rewarding. Thank you so much.
Thank you. Really appreciate you sharing that. Sise, are you with us? Can we come back to just you sharing what role you think community of practice it can play in getting families even more involved in nutrition efforts, specifically in IDP settings?
Sorry for the inconvenience of the network. So, as I said earlier, in IDPs, the communities are without support or with less supporters. As you know, in most IDP setups, it's 60 to 80% is women and children without adequate family supporters, without clear community-based structures, without clear service provision sites. That is having this community practice like mother-to-mother support group will help IDPs emotionally to know about the service sites where the nutrition or other services is provided, and to discuss each other, to share their experience, and to create spaces and to build their knowledge and to be emotionally stable. So generally, in IDPs where there is no clear community-based structures and where everything is disrupted, having community practice is very important. After we have the mother support groups in our IDP campus, the malnutrition screenings, the referrals, the classes, and the default cases, and their practices really improved. So having community practice in IDPs has most crucial roles. Thank you.
Thank you so much, Sisay, for sharing that. And we'll move into just looking at some of the questions that are coming from our participants today. And this will just go through to all our panelists, and feel free to jump in. A lot of conversations come around how we engage wider families, especially grandmothers and uncles and aunties. What approaches do you think we can use to engage these wider families and moving this beyond just the primary caregivers?
Yes, it's very important. Yes, other extended families has a critical role in child and maternal nutrition, like grandmothers, aunties, and other extended families. Yes, we try to including grandmothers, but to be honest, we didn't including aunties. And one of the main challenges to meet the number of members of the group to be easily managed by the mother support group leaders. As generally, yes, it's well recognized, and here in Ethiopia, the role of extended families like aunties, grandfathers, grandmothers in child and maternal nutrition is very critical. But as I said, to limit the number of members, and it's to be easily managed by the lead mothers, we including mainly the grandmothers, but it's identified as one of area of improvement for the future. But family defined that including the extended families. Thank you.
Thank you. And Solomon or Celestine, any thoughts?
Yes. So first of all, I would say meet them where they are. At the beginning of this engagement, you need to find out what they're comfortable with, and then meet them at that point, and then you can start changing their attitude towards childcare from that area. For instance, in this area, in Northeast Nigeria, you find it very difficult to see men and women sitting together to discuss anything. So the men have a place they call majalisa, where they sit together to under the shade or the tree, just to be able to discuss about anything. So that was the initial point of meeting for the men, and that is where the father-to-father support group evolved. Like I said, meet them where they are. Do not try to overhaul their system. Work with the system that is on ground, and that will help you to be able to garner their support. Basically, beyond that, it is to ensure that everybody in the family have a shared responsibility rather than a gendered duty. So this will help shift the narrative from we are helping the mother to nurturing the child together. So it moves the narrative from helping the mother take care of the child, which means the responsibility is that of the mother. Right now, it puts the responsibility to all the family members together, so that they are nurturing the child together. Also, maybe to say that community mobilization and engagement is very, very important. Meeting the gatekeepers of the community to be able to share these things will give you a lot of buy-in. And once, like in this area, once the key stakeholders are on the idea, especially the religious leaders, the community leaders, it is easy to be able to, amplify such thoughts in the community. Over.
Thank you so much. And I think when you just responded to that, three things stand to me: meet them where they are, and these are shared responsibilities, and the idea of building trust with the particular communities you're working with. Thank you so much for really sharing that. I had this other question just come in, and maybe Alex, you can start us with this, but how well can we enhance nutrition resilience and recovery for crisis-affected communities?
Okay, that's a great question. Thanks to whoever. Sorry, I didn't see the Q&A. But how do we strengthen resilience? The answer is really what Defined COP is trying to highlight: the importance of engaging families. Well, the experience we have shared with you are experiences that are part of our response to an emergency. But we always say in infantile feeding, in nutrition, in maternal nutrition, and in other public health interventions, we really need to start from the preparedness side. From us, the question asked is to build the resilience, is to make sure that our families are ready to cope with shocks, right? So for a mom, and I give you an example, the ability to support a mom in her breastfeeding journey, as Michael said at the very start, sometimes can be challenging. It's in helping her overcome issues. That means that when a shock comes, she will be able to overcome the same issue that may be even enhanced by the shock itself, and hopefully continue breastfeeding despite the disaster that is happening around her, right? So investing in our preparedness efforts, investing preparedness effort with the families we're working with in the communities, it's a key. We cannot build resilience without building family resilience. That's for me, it's a must. No, it's something that we need as agencies working in emergency or non-working emergencies to put in our mind. So it's investing in our families, investing in our communities. And this is what we don't see as often. And this is what we see as lacking when we need to respond to emergencies, where families may not be ready, when we highlight all the misconceptions and misunderstandings around infant feeding, when all the various, again, as I said, cultural issues are eventually even aggravating the situations, right? So it's how do we understand that if we work with families before an emergency strikes, then we can prepare them to cope with that emergency, to protect and support the infant feeding situation as well as the maternal nutrition. So it's really the work you're doing, Doreen, with the team, and the work we are trying to do as part of the overall integrated response. But we really need to invest more, and that's the call. Over.
Thank you. Thank you. Very strong call there. I just have two things to highlight. Really, Solomon, back to you. I think there's a lot of conversation about counseling, and just a question came in about couple counseling being a very innovative approach. How did that work in practice? How did you adjust, if any, for any gender roles? How did you engage fathers?
All right. Thank you so much. In practice, couple counseling is one of the, I would say, among the three approaches I just shared, the least used because contextually, before now, it is difficult to bring the male and the female together as regards to pregnancy and, childbirth, as well as, childcare. But it has been getting, an uptick. One thing to state is that where possible, ensure that the husband is quite comfortable in that setting. So you need to reduce the setting needs to be the traffic of women into that setting needs to be as reduced as possible. So you need to get a private area. That way the man is able to share what is in his heart. Sometimes in the initial points, if you don't probe much, the man doesn't open up. It doesn't open up. He allows the woman to do all the talking and everything. But when you probe and you let him, he becomes comfortable. It is easy to be able to get what is in his heart and what are his, his areas of confusion and where he thinks he needs to, where he needs to come into the discussion. Beyond that, also to state that you need to also state that whatever the man is doing, he's not entirely doing everything wrong. So you need to be able to build his confidence. You need to appreciate those things that have been done before in the past and use that as a stepping stone in terms of the things you would like to see improve over time. And understand that the change will not happen overnight. So you have to build follow-up sessions, sometimes into the homes of this couple. Those are the approaches that helped improve the uptake of couple counseling. But it's still a lot of work in progress right now. Thank you.
Yeah, thank you so much, Solomon. I think that sort of brings us to the end of our Q&A session. I do just want to acknowledge we did have a lot of questions coming in, Celestine, specifically wanting to understand this AI use and how, the trust and how accurate it is and all of that. So I think I'll just give you opportunity to sort of reply some of those directly in the chat. But in the interest of time, I would like to say thank you so much to all our panelists for your thoughtful responses and for everyone in the audience for such rich questions and comments that you shared. It's truly amazing to see how family engagement, specifically in IYCF, is not possible, but it's already happening, and we need more creative and innovative and impactful ways to share the lessons we do across the settings. Over to you, Nia.
Thank you so much, Doreen, for moderating. That was wonderful. And thank you to all our speakers for their insightful, informative presentations and for responding to these questions very thoughtfully as well. As we wrap up, we are very excited to announce that we are gearing up for our next meeting on using HCD to engage family members in complementary feeding in Mexico. That will be on October 28th. 10 a.m. Eastern time. And for those of you who have signed up for the listserv, you will receive more information on that, as well as the joining link and other details. We now have an exit poll that we'd like to have you all fill out before you leave. But I want to close out by saying thank you so much for all of you joining us today. And once again, please join our listserv. Thank you again to all our speakers. I think I speak for everyone here that the information and insights provided were incredibly helpful and important considerations when moving forward with this work, especially in these settings. Thank you all once again, and we look forward to having you join us next time. But please do take a moment to answer the questions in the poll. It shouldn't take you more than a minute. Thank you again.